Chairman, dear Franz, dear Maci, thank you very much for the invitation to Zurz. Once again, it's a pleasure for me to give a talk on low-dose rate brachytherapy. Let's start with the conclusions, so to speak. And the conclusions are based on the best evidence that's available nowadays, which are the guidelines. The guideline from Germany is on a very high quality. It's called S3 guideline, and I would like to translate for the non-German speaking part in this audience. Interstitial low-dose rate monotherapy is the primary therapeutic option for locally confined prostate cancer with low risk profile. And you can see that the agreement is very high, it's 97%. The same is with the European guidelines, the EAU guidelines. Transperineal brachytherapy is a safe and effective technique for low-risk prostate cancer. When you use the D'Amico classification of low risk, which you can see here, and a prostate volume that's about 50 or 60 cc, and a good IPSS below, we have heard it from Thomas Wieger, below 18. This is a very good level of evidence to be. But the best, these are guidelines on prostate cancer in general. I think the best guidelines on just locally confined prostate cancer are the ones from the AUA. And they just focus on T1, T2, N0, M0 prostate cancer. And they evaluated the 3 therapeutic options and did a very extensive literature research. You can see here all articles identified for this topic, but only 436 were suitable because they reported on outcome and they had a good methodology. These are curves for PSA-free recurrence, freedom from PSA recurrence over a period of up to 10 years in each arm. And I'd like to ask you, which treatment would you choose from an oncological point of view? They all look very similar. The first one is seed implantation. Next one is external beam radiotherapy, but with the old dose and the old techniques, not the very modern one like Professor Wiegel told you. And the third one is radical prostatectomy. This is the AUA guideline on locally confined prostate cancer. So if the oncological results are comparable, or I would say almost identical, then of course quality of life matters. We have now results up to 15 years, and it's emerging that also intermediate risk groups are well treated by brachytherapy. But what about quality of life and side effects of the treatment? Because they ultimately will determine the patient's preference. We have here a qualitative overview of the side effects of the 3 treatment arms. Of course, in brachytherapy, the main side effect is lower urinary tract symptoms, which are obstructive symptoms, but also frequency urgency syndrome. In radical prostatectomy, it's incontinence and impotence, and in external beam radiotherapy, it's mainly rectal toxicity. Just to show you one example for the problem of erectile dysfunction, a very well-designed, very good randomized prospective study, double-blind, comparing placebo versus vardenafil nightly versus vardenafil on demand. And these are very well-selected patients. You can see the mean age was only 57 years. They had low-risk prostate cancer, and all of these patients were potent before surgery. They had a bilateral nerve-sparing radical prostatectomy at centers of excellence, like Hamburg or Munich or Leuven or Milan. And after the study, the patients were asked, did your erection last long enough for you to have successful intercourse? And in the placebo group, only 1 out of 4 patients could say yes. So even for young, well-selected patients and bilateral nerve-sparing, the results with regard to potency are rather disappointing. So it's a trade-off as to the border of incontinence and impotence versus the border of LUTs in brachytherapy. And this is, at the end, a highly personal matter. We have in Switzerland a Swiss national register where every single patient, without exception, who has a brachytherapy is registered. And we have a complete coverage. It's clear that the follow-up, we have some dropouts. The follow-up is not 100%, as in all clinical studies, but we have now 1,050 patients treated in Switzerland with iodine 125. And you can see the median age is 64 years. That's about the same age as for radical prostatectomy. And they have, of course, mainly low-risk prostate cancer, T1C, Gleason score below 7, PSA below 10, but also some patients were intermediate risk. And there are several publications now in preparation. I just want to show you two, one with regard to oncological outcome and the other one with regard to quality of life. This is the follow-up. We have a very strict follow-up, pre-implantation and post-implantation, 6 weeks, where we also do image fusion with MRI and CT scan for quality control, and so on. And we have these tools to evaluate the patients. Now, the first one is on oncological results. The PSA bounce phenomenon. It's a temporary rise of PSA 1 to 2 years after seed implantation, where the patients get very nervous and the urologist too. We have now 580 patients with at least 5 years of follow-up from the Swiss register, also a minimum follow-up of 5 years. The recurrence was defined as PSA nadir plus 2 nanograms per mil after the bounce period. Overall, so far, only 3% recurred, and this is a comment. Selection is the key for good results, of course. It's always on whom you do the study, you get good results. But what you can see is that 1/3 of patients had no bounce and 2 recurred, and 2/3 of patients had a bounce, and 2/3 had no bounce, and 13 recurrences. This difference was statistically not significantly different, but there are reports from the literature that the bounce phenomenon is a good prognostic sign. The second one is quality of life, and we have looked at the comparison of open radical prostatectomy versus brachytherapy, about 200 patients in each arm, and we have looked at global health, physical, role, emotional, cognitive, and social, and there was a small tendency towards brachytherapy, in favor of brachytherapy, but all the results were statistically not significant despite enough statistical power in these groups. In Switzerland, brachytherapy is not widely used. Why is this so? I think there is a lack of availability. There are only 4 or 5 centers in Switzerland. The procedure is, I would say, a little bit complex. It's, of course, an interdisciplinary procedure with a radio-oncologist. In St. Gallen, it's Dr. Plaswil. And the medical physicist is also involved because he's doing those calculation with a very sophisticated software, the Variseed. But I think also there's a lack of awareness for this procedure in the population, but also for general practitioners. Contrary, for example, to the Da Vinci system, which is always in the lay press on television and so on. And there might be also financial and personal reasons. Dr. Grieser put quality of life as a hot topic for the patients, and I think brachytherapy is a good option for patients with low but also intermediate risk, and a good micturition. Selection is the key to success here. The oncological outcome is no doubt comparable to surgery or external beam, and the side effects and the complications, they are completely different between the 3 therapeutic options, and it's hard to compare those side effects. And what Dr. Grieser told you, quality of life is important for patients. Thank you very much.
Well, I think we're seeing, that was very, very nice. I think we're seeing a shift away from the mortality outcomes, which at best are very, very small, and you have to wait 15 years to get there now, to a real scrutiny about quality of life. And I think there's been a slight shift, which I'll also reinforce in a minute. So it's very nice to hear that. Any questions?
Dear Hans-Peter, can you make a comment on HIFU, strictly evidence-based medicine? I think the answer is clear, but please, for the audience.
I'm not a specialist for HIFU, of course. I have sent some patients, very few patients, for a salvage HIFU to Frauenfeld. HIFU is still in the guidelines called experimental treatment. There are no long-term follow-up, and I would not personally recommend HIFU as a primary therapeutic option in localized prostate cancer.
Dear Hans-Peter, can you tell us something about erectile dysfunction in the 1,000 patients in Switzerland? Did you do some validated questionnaires on that?
Yes, we give the questionnaires. We have the impression that erectile function after brachytherapy is in the first 2-3 years not so bad, but then it's declining also. But it's not from 100% to 0%, it's slowly declining. But of course, it's also a topic in brachytherapy, as it is in external beam radiotherapy. Normally, they respond very well to Viagra and Levitra and Cialis, but at the end, after 5 to 10 years, potency is also going down. That's clear.
Jean-Claude Killy.
Hi, Mark. No, I think we should have a new index. And we have the impact factor index, and I don't know how the name is, but we had reviewed the ratio between the number of scientific publications on HIFU and number of websites and hits on, on internet. And the ratio was, I remember, 1 to 1,200. So maybe we should have to scrutinize several aspects of our profession where when you have a 1 to 1,000 between internet and what is scientifically published, maybe that tells us something.
Okay. Thank you very much.